Okay. So it's so nice to see everyone today, and we thought that we would just have a few minutes to be able to talk about some of our reflections of the conference on Sunday. And the title of the conference was Humanizing Ourselves for the Other. I think this is maybe our fifth time um, to use this name. A lot of times we'll add certain things in there, like the context, but this time we added um, belief and growth and movement. And, you know, words that I feel so privileged to be able to be using with you guys today because it's so wonderful to have these opportunities to talk. And we have so many similar ideas on our passions for why we are even doing this. So, Rod, I just want to bring it back to what you were saying a few minutes ago before I started recording. But I was asking you about because you weren't able to stay for that part of the event where some of the people with lived experiences came in and talked about um, their experiences with treatment. I forget, what did you call the treatment? I forgot. You called it the treatment that you called it on the conference. I love the title that you used.
You're referring to commercial psychiatry?
Yes, 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 yes. And let me just get out of this really quickly. This is going to, I think, uh, um, and 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 so I think all of the people who were panelists that had the lived experiences all talked about this in one way or another. And so when you were able to listen to, I think there was one person before the mom and dad, but I'm not quite sure. And
Maybe two. Yeah.
and so
The- yes. Yeah. And the impression is this message keeps getting repeated, and it's hard to it's in this field it's very hard to make generalizations, but um, to a bare minimum, the massive amount of people going through uh, this kind of a situation or experiences where they are submitted to the grinding, the usual mill of commercial psychiatry, where you receive a couple of diagnoses or more, and then you receive a couple of medications or more, and every medication is good for everything. And then you become that diagnosis, and there's all the implications. We know from a diagnostic perspective, as it is done, that doesn't take into account context or history or anything. It's just a topographical description of what the patient is experiencing. Um, and one of them being the removal of responsibility from the hands of patients. It's a sort of a professional enabling, or maybe you know um, a imposed helplessness, meaning you just have this disease. It's not even a disease, right? You have this condition, and not a lot you can do other than take a pill, which is fostered by our scales, right? The GAD-7, PHQ-9, they all foster this idea that no scale ever asks, have you made any friends in the last month? Have you elected a purpose for your existence? Have you found any sense of meaning? Have you done any have you done anything? It's basically, are you still feeling the same? And the message is, okay, then we need the underlying message is, it's okay to be passive because the responsibility for your improvement is on the pill, on this or magical psychotherapy technique or what something. And which is, of course, the humanizing, right? Um, and so there's so many people going through this and then reporting, and that at a bare minimum, let's assume we were just wrong about everything. Let's assume we are let's say our view of reality is biased, not the view of reality of commercial psychiatry. It's so many people that to a bare minimum, we would have to review the practices. We will have to start considering that the level of uniformity that comes from commercial psychiatry needs to be abandoned, um, for a more plastic approach, for a approach where you say, well, we're really not sure what does what here. And it's not a decision that a doctor could make. It's a decision that the patient has to make. It's like, what is this process? What we have right now is this fake sense of efficacy, where people refer, of course, we know psychiatry is based on a pseudoscience, but it's still, we have randomized controlled trials with all their limitations. They obviously they favor drugs. It's hard to do a randomized controlled trial about what you do in your clinical work, right? Nothing complex can actually be tested with a randomized controlled trial. But there they are. The randomized controlled trials are there, and we have this sort of a floating sense of truth behind these things, or this maybe shouldn't call truth, but a consensus. And then the whole field behaves as if we don't need to be discovering new ways of doing the job. We don't need to be flexible. We don't need to question things, because, this is science. I remember I was talking to a friend of mine in my podcast a long ago, when I was starting my podcast, and he was a brilliant guy. And I brought up psychology and psychological theories. Because you see, one thing about psychological theories is because they can become a trap, but they just need to be so good as to allow a large number of people to identify with it. Because we have as many theories of the mind as there are minds, right? Everyone has an idea of how they work or how the mind works. So all that Freud and Jung and Skinner had to do was to come up with something that serves a larger number of people, that can be useful for them, that can help them have a framework on how to operate change, how to engage in movement, how to recover, how to have a meaningful life. Anything that is slightly more, or maybe described in vague terms that are vague enough to apply to more people, can be considered a psychological theory, and in that sense serve humanity. Of course, keeping in mind the traps that can come with it, right? When you stop considering the complexity of things and reduce then the whole experience to that little bits that you believe. Let's say, oh, this is all your unconscious, this is all conditioning, this is all, So when I mentioned psychological theories and psychotherapy approaches to this colleague of mine, he said, "Oh, so you want to bring religion into the discussion?" And his claim, and I understand his claim, is to say psychiatry is a science and this is all speculation. It turns out, however, that the data behind psychological approaches collected over the last 100 years not only is very solid, not only survived the longest time despite difficulties, despite being partial when it comes to helping, and I think that's inherent to what we do. The data is also more reliable than the data from pharmaceutical companies because it's not as biased, right? We don't see the Freud family still enjoying the royalties of a company that created the concept of unconscious, or we don't see the Skinner family swimming money on account of the patent of conditioning, right? But we do see a medication like Seroquel paying almost $1 billion in fines for false advertisement, and we still know that that is less than a tenth of their profit. So the false advertisement is sort of and the loss of the money due to false advertising can easily be seen as part of the publicity campaign needs to pay for it because the profit is so huge. And the data is so bad. The data supporting current psychiatric practices is so unbelievably limited. We have, you take schizophrenia or psychotic syndromes, if you will, and the damage that antipsychotics cause to health and mental health and the brain itself, for a remission rate of 12%. And you take antidepressants with the increased mortality, risk of diabetes, changes in sexual drive, impulsivity. You see, we already know from research from uh, behavioral psychopharmacology that SSRIs impair consequence-based learning, which is the implications of that is just like if you put 5 minutes into it, you're going to realize that impairing consequence-based learning means stagnation. It means repeating the same mistakes. It means becoming insensitive to consequences, and as such, impulsive, which is something we know since the 80s, that serotonin is actually an acute stress neurotransmitter that increases your chances of acting upon situations acutely. Chronically is a different animal. And we know for teenagers that antidepressants makes them impulsive. And then what's the remission rate of depression? Let's assume depression as a thing. What's the remission rate of depression with antidepressants? It's 20%. What is the remission rate of depression that is spontaneous? It's also about 20%. So we should at least behave okay as if we didn't know. But we have this resource, we're not so sure how it works. And then when new approaches, because that would open the door to new approaches, that will open the door to a different mindset when it comes to helping people live their lives, where we say, oh, anything goes, man. What do you have in your mind? What fits you? What's your story? What is your path? Because now people say, well, I'm doing, I find my mental health doing, I don't know, collecting crystals or whatever. The typical response of a mental health professional these days would be like, it's cough of it, right? Say, oh, really? Like that's not real. But that is as real as what we are doing with our data, and serves the purpose of that human being. And so at least we could have some open-mindedness where we will say, well, man, we have this set of resources. What can be used, right? Because there's really no science as people like to define it behind this artistic endeavor in any of the sides of the table, right? Like there's not a lot of science behind. There's zero science behind the diagnosis. There's very little science behind the treatments. And then, on the other hand, we have humane or psychological approaches where a good bit of them are like based on impression, intuition, idiosyncrasies, and at least we're doing no harm, as Hippocrates hoped we would be doing with that. Is not as harmful as the chemical therapies that are so-called scientific. So that's why those meetings for me are always very interesting, because the people are real. They're there saying, hey, this happened to me. You cannot turn your face anymore. This is a thing. You're not reading it on a website. You're not reading anywhere. Here am I telling you, my son was hurt by these medications, and then comes the other bit, that is how to fight the forces that push us in that direction, right? The as we spoke during the conference, the forces that will tell people, well, but I saw an advertisement of Abilify on TV, oh, but I was taking that drug back in the day, but my neighbor takes this, but everybody believes that, and I think you're nuts. So plus the legalities of the field, right? Where they're going to say this insane concept of standard of care, because all you have to do for standard of care is having a large enough number of people doing something harmful or stupid, and then you find yourself having to justify why you didn't. Like the example I always use is with quetiapine, is that I have asked more than 100 professionals in my career, easily more than 100, it could be 200, I don't know. Would you ever take quetiapine if you had insomnia? And not once people said I would. Not a single time a prescriber said I would take quetiapine if I had insomnia. Not once. And but it is not that not only we continue to offer, patients continue to accept, which makes us question what information about this drug is being divulged.
Yeah.
And it's a drug that increases mortality, heart attacks, strokes, diabetes, cholesterol, obesity, Parkinson's disease, dementia, has acute cognitive impact, it doesn't make you any smarter. And we have children taking it, going to school and taking tests. We have teenagers going through schooling, taking tests. We have adults trying to negotiate a very complex world while swimming on this drug. And that somehow becomes the standard of care. Why you didn't try quetiapine for this patient if something goes south, God forbid.
And that father was talking about informed consent. I don't know if you were able to, and he said at some point in time, someone must have mentioned something, but he also said that it was his responsibility, or this is my interpretation of just listening to it this last time, that it was his responsibility to look into the pamphlet, right, that comes with the medications. So as a consumer, he would know, in particular, he was talking about tardive dyskinesia, because when he really decided that this wasn't worth it is when he saw his 12-year-old having tardive dyskinesia.
Yeah.
And being very frightened.
Yes. Yeah. And people frequently ask me why most of my patients don't take any chronic medications. Mm-hmm. And again, I just want to say this, I have nothing against drugs. Mm-hmm. Okay. I frequently use the example, people think I'm joking. No, I like to get on a Friday night and have a sip of alcohol. I like to every so often have some nicotine from a cigar. The challenge is that with the little we know about the brain, if I were to, let's say, I like the way gin makes me feel. And if it was sustainable, I think I would like to start all my days with that feeling.
Right.
But it's not sustainable because within 2 weeks, I have to double the dose, and maybe another 1 or 2 weeks, triple the dose. And eventually, I'm just going to be not able to operate pursuing that feeling. And the reason for that is because this machine, turns out, is designed to cope with reality. Has feedback mechanisms that we don't know. And we know some of them, and the little we know about them, it tells us that the chronic use of drugs does not make a lot of sense. And I'll leave it open and say, unless an exception, a state of exception, meaning, yes, it is possible, right? I'm really open to say it makes sense. It's a result. It's a resource that it's not hard for me to imagine a situation where someone needs to take drugs every day. I don't have a problem with that. I just don't believe that is all of us. it's a state of exception as opposed to say we all should be swimming in these things that will create some sort of tolerance. And now you have two problems. Whatever you're trying to address with the drug and the effort to clean it up from it cannot be done easily. I mean, antidepressants have a 50% rate of moderate to severe withdrawals. And we're talking about antidepressants. We're not talking about benzos. We're not talking about stimulants. We're not talking about opioids, antidepressants. So, so when it comes to
Except for the antidepressants that have the stimulants in them, right?
yes, yes. So yeah, so we have Wellbutrin, for example. It's a stimulant in many senses, and the thing we face then is, do people know what they're taking? And that's exactly the criticism I used to make about the quetiapine example that I give, is that if we wouldn't take, but if we offer and patients take it, what is that we're not telling them about this drug, right? And all these things already have, and that's what puzzles me the most about standard of practice. So people ask me all the time, why is that your patients don't take chronic meds? Man, I know what my goal is with that. I'm just trying to avoid chronifying people, right? So they can come, and for as long as I'm useful, they stick around. And when I'm no longer useful, they go on their merry way. And when they need it again, they come back again. And guess what? That's how it goes. And it's not because I'm super talented. It's just the paradigm under which I work, saying I'm not going to chronify someone on a medication so to force him to come back every month for something that, may solve itself within a month or 2 months. So then, or something that the patient may address by making life changes. So what I noticed is that once you tell patients all the reasons by which you would not take a drug, and you don't have to present that way, right? You can just, because you see, one challenge is when I said that on Med in America, I said, you don't have to say, I wouldn't take this drug. I have to offer you this. You need to know there is this resource. I wouldn't take it myself. You don't present that like that. You just say, these are the side effects, the same ones that would keep you from taking. And I was criticized in the comment section for not saying that, for not saying I would not take it. And the reason I wouldn't say that most of the time is because one of the philosophical and ethical, let's say, rules of medical practice is to respect autonomy. So I would present information and say, it's your call. And the natural result of that, when people start hearing antidepressants causes diabetes, see, well, yeah, there's an increased risk of developing diabetes that is time and dose dependent to the antidepressant, any SSRI. They go like, wow. And how about the side effects on sexual side effects? Yeah, sexual side effects. Some people may report loss of sensibility in genital tissue that can last like months, and some people may claim permanently after you stop taking the medication. So it should impact your life significantly. Um, well, I think I want to wait another month, and all of a sudden, addressing my problems, changing my reality seems to be a more attractive option than staying put in this emotional concentration camp while trying to generate well-being with a chemical.
I'm just going to jump in here because what this reminded me of is that my mother supposedly had breast cancer from the hormones that she was taking, that there was something that um and I remember when she was passing away, her doctor said, I would not take hormones if you were going through menopause, because it wasn't my mom, it was my mom, my aunt, and another aunt, and another aunt, and my cousin, who had all taken lots of hormones. So I remember when, you know, I was premenopausal, and I went in to see the gynecologist, and he said, well, you might want to start on hormones. Well, I didn't even question him. I just want you to know. Like he starts to give me the free hormones right across the table. And then all of a sudden I said, the doctors had said something, when my mom was dying from breast cancer, that it might not be a good idea for me to take that. Immediately he pulls them back, right? And then, says, well, maybe it's not a good idea. But what would have happened if he would have said, oh, well, that's old research, right? Well, maybe that's not what's still going on at this point in time. And as we know, that research is not indicative of standard of care, but it's indicative of the business of medication. And so, you know, I'm a clinician that, as we both know, that I go back to before people were put on medication, right? They were put on medications for very short periods of time with the intent that the medications, you would always be taken off the medications before you could even develop a dependency to them. And and then seeing how, because of, again, the sponsored research, then created these stories that, oh no, this is now biological and they have a biological need, and it's a biological fix of what they're doing to correct the depression or the schizophrenia or the anxiety or anything like that. And so my coming from a position of never putting people on medication, like I was not trained in that area, that we even, most of the psychiatrists I knew at that point in time were um, psychologists as well, right? They talked with their patients, their clients. It wasn't all about, well, this medication will be the standard of care that will solve whatever issues that you're going through. And so I never had clients on medication. I never had clients that went into hospitals. And I was talking to somebody about this 2 weeks ago. And it's because we were able to create this solidarity among the family. So that means if someone's having a very difficult time, instead of the first thing that you're doing is thinking of referring them out, how does the family help during these times of immense suffering? And I know that that case that you were talking about before with DV, you couldn't really do that in that case because that wasn't a safe environment for her to be in. But there are safe environments where our clients find that they and I see this a lot in the parents, almost like the parents that were talking on Sunday, but they're there to help soothe their family members and what's going on. Whether, and it used to be, if we think about it, it used to be aunts or uncles or grandparents or cousins. We had so many support systems to pull from that the necessity for needing more acute care wasn't there, because you had these safe spaces of people welcoming you and supporting you and nurturing you and and telling you things were going to be okay. Maybe I went through it, your uncle went through it, your cousins went through it, whatever it was. And now those types of stories or narratives surrounding these immense struggles that people have are no longer there. Those have evaporated. And so it's quite troubling to think that, that we're having this conversation where these products do not deliver, whether they're psychiatric or they're psychological, because we can get so bound on particular theories that are going to remove symptoms.
Yeah, yeah. And the removal, the suppression of the negative experience. When I spoke to, there's a nice book called Emotion, Charlie Kurth, Charlie Kurth, Charlie Perth. I interviewed him in my podcast, and the book is very good because as I was writing my book that is still in the works about this new paradigm of care that I use on true psychiatry, I ran out into his book, and I and I found this confirmation from a philosopher, which is for me is a very meaningful. When you reach a conclusion and you want to check what somebody else has thought about it. And the question was, emotions have a sensorial component. They're telling you the negative emotions, the positive emotions, they're telling you something about your reality. Maybe anxiety is an exception. Maybe love is an exception. They seem to be uh, uh, inexorable, meaning come from within and they will come no matter what. Um, that's my impression. Love and anxiety seem to be emotions that have a life of their own, and they are quite independent of the outside world. But which is not the same as fear. Um, but I spoke to him about it, and basically got to run ideas by him, and he said, yeah, emotions have a sensorial component and a motivational component, right? So frustration tells you something about your reality is not going as expected, and frustration pushes you towards doing something, so frustration ceases to exist. And what that is quitting, right? Once you quit, then frustration is gone. Anger wants you to hurt, right? Anger can come out of different contexts, but once you hurt something, you feel relieved. You no longer feel hurt. Um, Loneliness wants you to, connect, and so forth, so on. And those things are self-evident. They're not necessarily theoretical. But then we develop a whole medical field, and maybe some psychological techniques that aim at just reducing the negativity of your feelings. And as such, we are fostering a disconnection from reality. And because we are suppressing something that comes with a motivational component, we are also fostering stagnation. And so we do that as mental health professionals to the very people that desperately needed movement and change and new. So I'm going to restructure you cognitively so you don't see your problems as a problem anymore. Or the way acceptance was, um, let's say, misappropriate from Hayes and slapped on top of psychiatry, um, as a way to say, well, that's what it is, which is never what was meant by Stephen Hayes. Stephen Hayes, if you talk to him 5 minutes, you understand that movement is what this guy has on his heart, as opposed to accept for the sake of staying where you are. No, accept the inevitable, accept the fact that you need to move, accept the fact that life is more, accept the fact that if you're feeling down, you should be doing something about it. It's not just accept the pain of life and sit there stable and controlled, right? And then we have mindfulness also, slapped on top of a medical field designed to suppress experience. They say, well, and then there's mindfulness that is designed to fill the experience. It is just insane, and is obviously a result of, as Skinner would say, once you know the reinforcer, you understand every behavior. Which, translating for less technical terms, will be, once you understand the motivation, everything makes sense. And then you look to the managerial era of care, of medicine, of mental health and psychiatry, and then everything makes sense. Of course, we are here. This field is ended up being developed having in mind the concept of normality, which was mostly developed by eugenicists. And no, please don't be normal. Like, be you, whatever mess you are. The and everything seems to move in that direction of so the word neurodivergent, it's a word that makes zero sense, because I haven't found two brains that are the same yet. So what is a neurodivergent person, right? If we are walking on the streets and someone yells, um, doctor, both of us may turn and look, and we have that in common. But if they yell, hey, dude, probably I'm just going to look back and you don't. And if say someone says, hey, Susan, then you are going to look back, and I'm not going to go. Or so they say, hey, girl, you're so we already know we are wired differently. Something is different about us on that very basic level. Um, the same for our emotional experience, right? There's no reason to believe two people feel the same, and yet psychiatry uses terms like poor emotional regulation, as if we were all feeling the same, but you don't know what to cope with that, and he knows how to cope with that, as opposed to assume the obvious that you feel things very intensely, and that guy is a bit more flat emotionally. And so it's once you see the forces behind it, like then okay, makes sense, because if people start realizing, okay, I'm not sick. Okay, I'm going through something. Okay, this is a valid, this is a legit human experience. Um, I don't think I need to suppress it, because the alternative would be to have a more fulfilling life instead of suppressing my motivations to engage in movement. Then God knows what would happen with all the profit.
right? So what would happen?
Well, it will probably, I don't think it will disappear, but it will probably be cut by 90%. The profit, the whole profit of the industry will be cut by 90%. I think we'd still have a use for them, for the drugs. But yeah, and it's something we cannot have. Surprisingly, pharmaceutical company goes through these self-reinventing cycles that is usually associated with the release of new patents, so that they have to diss the old, right? Um, when antidepressants were released, there was pretty much an epidemic of people taking benzos, and all the issues with benzodiazepines were pretty much like, kept quiet. But then benzos got demonized on account of selling the new things, and then in the last 10 years, maybe from uh, time's passing a bit too fast, I shouldn't say 10 years, maybe 2010 to 2020 roughly, um, we had all these antipsychotic patents. And I think it was around 2012 that olanzapine was first approved in Canada for bipolar treatment as a mood stabilizer. So now antipsychotics are mood stabilizers. And why is that expansion? Oh, because they're good options. When you look to the data, they're not really good options. They're not really great mood stabilizer, whatever a mood. Let's call mood stable. What they're trying to say is it's going to prevent you of feeling depressed or manic if you carry a syndromic diagnosis of bipolar. So they kind of do have an effect in that regard, which is highly questionable when you see independent research on monotherapies. Like, how long can you take this drug before you have a mood episode, and another drug needs to be added? And it's less than a year, which we don't know the natural history of mania. It could be that it's doing nothing, right? But there are some cases where the patient is going to tell you a very convincing story. You say, okay, well, that's your story. Keep up with it. All good. No prejudice here. I'm sure some people will respond to drugs. I have no doubt of it. I just wish they would know the consequences. And then, so during those 10 years, more or less, we had all these patents of antipsychotics brand new, and then they all get approved, or either not approved but off-label, researched and marketed for using with bipolar syndrome. And bipolar gets expanded from a 3% prevalence diagnosis to maybe now something like, I don't know, 1 in 20 Americans, maybe 1 in 10 Americans have a diagnosis of bipolar now. Like, used to mean something when you said, do you have any people that have been manic in your family? Yes. Do you have anyone with bipolar in my family? Oh yeah, my son, my aunt, my cousin, my mom, my grandma, everybody now is bipolar. So with that expansion, of course, follows the patent, right? And when I ask my colleagues about it, I have heard this more than once. They'll say things like, well, our diagnostic capabilities improved because we want to write it, which is the same as saying it became easier to diagnose something because the criteria is more loose. And if we give them the benefit of the doubt, we would say, okay, our diagnostic capabilities, which they didn't, it's still the same checking list of emotional experiences. But instead of, let's say we're just not talking about more false positives, let's just say there was an improvement in the ability of diagnose these things. Why the expansion didn't happen with schizophrenia?
Mm-hmm.
And schizophrenia is still a 2% prevalence diagnosis. Why the expansion didn't happen with it? Well, because it's not desirable. It's not sexy to say I have schizophrenia. It's still very much stigmatized. But there are no marches for schizophrenia. There's only marches for glamorized conditions. There's only marches for bipolarity, because bipolar disorder seems to not only be misunderstood or expanded, but also seems to justify every uh, human trait that can possibly be related to unpredictability, impulsivity, anger, aggressiveness. Everything now is bipolar.
Everything that
I
makes
can't remember.
right? Everything that makes us a human, right? In certain.
Perfect. I remember when I was director in Massachusetts, having a connection during the this a case discussion. They were talking about a 14-year-old girl who her parents put on timeout in her room, and it forbade her of going to a gathering of her friends, the little party in the neighborhood, and she got out of the house through the window and kind of escalated down and went to the party. And the professionals involved, of course, because I think we spoke about that before, if I'm not mistaken. What makes a shrink is a life of academic achievements and boredom. So this lady said, "Well, that's a pretty risky behavior, and I think that's bipolar." And I just felt like, wow, I wish I could take you to Brazil to see what teenagers do there. We have a whole nation of bipolars, right? So of course the patient was put on Risperdal, I believe, and another mood stabilizer, God knows what, which is another joke. Like everybody has ADHD and bipolar, so I'm going to put you on a dopamine blocker, and I'm going to give you a medication that increases availability of dopamine at the same time, under the premise that they act in different parts of the brain. To sure. That's how targeted our therapies are. No, and so I lost my train of thought here, but basically, I think this expansion happened, and now most of those antipsychotics are off patent. And there's a very good paper on because at the same time that was happening, there was all this research showing how adding an antipsychotic to a antidepressant regimen would improve PTSD symptoms, would improve generalized anxiety symptoms, would improve major depressive disorder symptoms. How antipsychotics were this wonderful thing. Now there was a paper, I think in 2020, very good one, showing, comparing, I think was done with 80,000 folks, comparing mortality by all causes, premature mortality by all causes, in a group of people that were just taking antidepressants versus a group of people, roughly, I think it was 40,000. I have it, I just don't remember, where an antipsychotic was added to the antidepressant. And the mortality added by adding an antipsychotic is something like higher than the mortality by suicide in the same population. That is, at that time, was 14 per 10,000. And I think the mortality added was like 37 per 10,000. So like the patients are better off on their own than taking those drugs. Now here comes the detail. 100% of the authors had papers financed by pharma. So okay, we ran out of patents. Now we can actually start looking to this thing, and God knows what's about to be released in the market, because now we have the hallucinogens, the microdosing of things. There's a new holy grail coming. When the other thing I saw, when people could no longer sustain the biochemical imbalance hypothesis for depression, now became a metabolism hypothesis. So nobody's allowed to be sad anymore. It's a metabolism. As we debunk this hypothesis, the pseudoscientific hypothesis, new ones come up, right? And when the metabolism thing comes up, you think, oh, it must be by chance. No, there's a new antidepressant in the market that is a neuronal steroid. So then you go, all right. And this way we chase our tails.
Right. And the problem is that, one of the things that frightens me is that I very much agree with you talking about the drugs, right? People use drugs and people use psychiatric drugs, right? But again, they're I think people want altered states of consciousness when things get really hard, right? But
Yes.
that doesn't mean they're going to work and doing any of these things that they're told that they're going to do. And then what happens is that people have so much hope in these drugs. And so they go in the hospitals and they get a change of drugs, and then they go back in and then they go back in. And then sometimes they just never go back in, because at that point in time, the incredible hopelessness, as you heard from that one person that was talking in the on Sunday, just it and so that's why for me, um, these conversations that we're having are so necessary, and so I hope that, we can continue to do this, because
Absolutely.
um, I think there's a lot of people interested in ways to do things differently, and they deserve to know. So thank you so much for spending your time with me. I am going to stop the recording and